It's a pure joy today to welcome Dr. Eric Levi to Recalibrating with Sharee Johnson. Eric is an otolaryngologist, head and neck surgeon with subspecialty interests in complex airways diseases, head and neck tumours, sleep and saliva gland surgery. He trained in Melbourne, Canada, Brisbane, and Auckland, New Zealand. He is an academic and consultant surgeon at the Royal Children's Hospital, Melbourne, the University of Melbourne, Eastern Health, and Melbourne ENT Airway Clinic. Eric has completed a science degree in psychology and master's degrees in public health, tropical medicine, and health administration. He has published over 30 papers and presented over 150 lectures internationally, including talks on health and wellbeing in surgeons. It's my absolute joy today to welcome Dr. Eric Levi to the podcast. Eric is an otolaryngologist. No, I'm still not saying it right.
Well
Did I get it
done.
right?
Close enough. Close enough.
Otolaryngologist.
Yes.
Eric is an the more I try, the more I'm going to stuff it up. Eric is a otolaryngologist, head and neck surgeon with subspecialty interests in complex airway diseases, head and neck tumors, sleep and saliva gland surgery. He trained in Melbourne, Canada, Brisbane, and Auckland, New Zealand. He is an academic consultant surgeon at the Royal Children's Hospital in Melbourne, at Melbourne University, Eastern Health, and Melbourne ENT Airway Clinic. He has completed a science degree in psychology and master's degrees in public health, tropical medicine, and health administration. Eric has published over 30 papers and presented over 150 lectures internationally, including talks on health and wellbeing in surgeons. Welcome to Recalibrating with Sharee Johnson, Eric.
Thank you so much, Sharee. I sound really smart, but I'm not really.
Oh, well, that's debatable, and maybe we'll find out today, right? It really is a joy to be having some time to talk with you. I always feel very appreciative of people's time. So you've got 3 fellowships, Eric. You gained them in Australia, New Zealand, and Canada, so you travelled as well to do that study. I wonder if you can paint the picture for us. What's a typical month look like for you at work at this stage of your career?
Thanks, Sharee, for having me here. I've always watched you from afar and we've crossed paths multiple times. Thank you so much for all the wonderful work that you do, both for doctors and the community in general. Love your book as well. Now, what do I do? So, as an ENT surgeon, I divide my time between the public hospitals, Royal Children's Hospital, Eastern Health, University of Melbourne, but also in the private as well, about a third in each quadrant, so to say, a third in each quarter. And yeah, I mean, on a typical week, basically, it's a 7 to 7 job, and with lots of after hours meetings, on calls 1 to 2 nights a week, and one weekend in every 3 or 4. Juggling the busy life. I think all of us are busy. We all have our different kind of puzzle pieces that we put together. For me, where I am right now, about 11, 12 years since becoming a surgeon, that's how I juggle it. 2 days at the Royal Children's Hospital, a day at Eastern Health, and a couple of days in the private. And on top of that, just a bit of educational, teaching, community work here and there after hours.
And Eric, for people who aren't surgeons or haven't been around the theatre for a long time because they did their internship a long time ago, or who are nurses or occupational therapists, other people,
Yeah.
can you talk a little bit about what you do when you're in your office? Because doctors say
Yeah.
that I'm in clinic. What does that
Yeah.
actually mean?
Yeah, yeah. So typically we would say, for example, like this week on Monday, I spent all day in the hospital consulting and then basically starting my clinic at about 8:30 in the morning and then finishing the clinic at 5 or 6 in the afternoon. Typically, there is a lunchtime meeting. Every Monday, there is a Monday morning, 7:30 a.m. Zoom meeting with the rest of the team. And often there's an educational meeting at 5:30 to 6 in the evening. So that's kind of a day of consulting. And then the following day on Tuesday was a day of operating. Basically, operation starts at 8:30. All the sessions start at 8:30. This morning in the private, my operating session starts at 8. So you got to be there from about 7:30, see all the patients, go through the process again and do the operations. So life in the surgical world is basically sessions of clinic, sessions of operating being put together in all sorts of various different ways, probably on average about 50-50. Half of it is consulting, the other half is operating. And then everything else is outside those sessions, meaning the emergency cases, seeing patient the emergency, visiting a patient in the hospital for a ward round. Tomorrow morning, I have to see my private patients that I've operated on today. Got to see them in the morning, so drive up to one hospital, and I'll have to drive to another hospital to do a clinic. We have a complex drooling clinic in another hospital, and then after that, I'll be driving to my private practice for an afternoon of consulting. So week to week, it's slightly different, but essentially blocks of consulting or operating with emergencies outside those hours.
And with all that juggling, you're still smiling.
I guess we've been doing this for a long time now. We get used to it, and we
Yeah.
actually love it. Maybe there's a part of us that just can't sit still. My wife is an infectious diseases physician, and her days look very different. She does 2 to 3 hour long ward rounds. She has 2 to 3 hour long meetings, case studies. She has clinics. When she's on call, she's on the phone a lot. So a lot of things do happen around the place.
And let's go back a little bit, Eric. Can you tell us about when you left school and you came to university, you came from overseas, so you had some recalibrating to do then, and we're very interested in that on this podcast. And just walk us through a little bit from when you went to med school, or you actually didn't go to med school first. You science degree, studied
Yeah.
psychology, man of my own heart, and then you went on to medicine. Can you walk us through from, that whole journey until now?
Yeah. So, very interesting. I was born in a non-English speaking country, in a developing country. I grew up non-English speaking. I came to Australia when I was 17. So I picked up English only in high school when I was about 14. So I came to Australia at the age of 17. My mom is an educational psychologist, and that's probably where I fell in love with the idea of doing psychology. So I came to Australia wanting to do psychology, basically just to finish my degree in psychology. Detours in life. I met a young, beautiful lady who was doing medicine at that time, and the rest is history. So I went into medicine, to get a wife, maybe if I could put it that way. Her father was a very traditional, who said that she comes from a family of doctors, so two older brothers, and her parents are all doctors. So basically, they said, you can't go out with our little sister, with our daughter, unless you're a medical student. So I did medicine for that. We're still married. We're still married for 23 years now. So that's how I got on from psychology to medicine. Was basically, obviously it's a service industry still, helping people industry. So that transition to medicine was a detour, but a detour that I look back and said, yeah, well, I love being where I am right now. Interestingly, when I did medicine, of course, everyone thought, oh, you've done psychology degree, you're obviously going to be a psychiatrist because that's kind of the natural inclination, right? You've done psychology, why don't you do psychiatry? But I guess I was one of those who kind of loved a lot of things. And when I was doing obstetrics and gynae, I loved it. When I was doing anesthetic, I loved it. When I was doing emergency, I loved it. So it was all really, really, really interesting and exciting. But surgery was the thing that I finally fell in love with, really. Just wanted to do surgery. Although I wasn't quite sure of what kind of surgery I wanted to do. I had a general inclination towards general surgery, ENT, plastic surgery, and I kind of fell in love with ENT after doing a few rotations or terms in ENT.
Some young doctors have said to me it depends a lot on the consultant that they're working with that helps them decide which specialty they went into.
That
Did
is
it
true.
play a role in terms of
Yes.
mentorship or the people
Yes.
that were guiding you?
Absolutely. I think meeting the people that you grew well with. So when we were rotations, doing different rotations, you kind of got a feel of the different units, different departments, not just the job itself, but actually the community. And I think it was ENT that really where I kind of gelled really well with. What's also interesting is, and I think maybe this is a circle of life thing. My youngest sister was born deaf. So we grew up in speaking American Sign Language, a bit of Australian Sign Language. She's now in London, living in London, and we do a bit of British Sign Language. But it's almost like when thinking about surgery, well, she had cochlear implants, she was born deaf, wouldn't therefore do ear surgery be one of the things that you might want to do? And it turns out that, I end up doing something else just slightly different to that, in head and neck surgery. I don't do cochlear implants, my colleagues do, but that was almost one of the other things that came up as well. So yeah, maybe early exposures to all those things.
Yeah, maybe the psychologists in us both are kind of curious about what was happening unconsciously there.
Exactly right. Exactly right. I always thought about that sometimes.
Yeah. And Eric, after you made those decisions and thank goodness you were able to integrate into the doctor family, your
Yeah,
in-laws,
that's right.
and then you've done, multiple other fellowships. You've been on this journey of studying, other things.
Yeah.
Is it just this innate curiosity? Tell us about
I,
these decisions.
I think so. I mean, my wife says, I don't think you'll ever be fully satisfied with where you are right now. You're always wanting to do a little bit more, wanting to study a bit more. I mean, I did public health and tropical medicine. I did health administration as part of my master's. And I think that was really driven by the fact that, I kind of like systems thinking as well, kind of like to look at the big picture. Public health and tropical medicine was something that I was interested in, but Master of Health Administration as well. I mean, we often talk about the challenges that we doctors or clinicians face in a hospital. We often talk about how it's always the hospital admin, hospital admin, hospital admin. I figured, look, if I wanted to find a solution to the problems, I probably should speak their language too. And I think that was one of the big drives for me to think about health administration, Masters of Health Administration, because I really wanted to understand the language, understand the system, and figure out where we could potentially make a difference in that sense. Yeah.
You find any answers in the sense of were there surprises? Were there things that you didn't know and didn't understand before you did
Yeah.
these studies?
I mean, yes and no. Some of my not fear, but my suspicions were founded. Of course, you learn a lot of new things, like
Mm.
having to learn the statistics, having to learn the accounting of health services, having to understand how difficult decision making at a systems level would be. That's always something that I appreciate. But on the flip side as well, again and again, it just shows that sometimes in a place like the hospital, there are multiple different ways of thinking about the problem, and sometimes the languages between specialties don't really align with each other. The priorities of a health administrator, the priorities of a surgeon, the priorities of the charge nurse are can all be very different. Finding common grounds there, I think, is the important part. So in a sense, I learn a lot, and hopefully that will help me in making changes both at the micro level in our department, but also higher up towards the systems. No, I'm not planning to be a CEO of a hospital. I love operating too much to be doing meetings all days, or doing all of that. And I think there are people who are better qualified than me to do those things. But at the same time, I think understanding the language of the economies of a hospital, the business of a hospital, does help. And at the end of the day, we're all advocating for our patients,
Mm.
whether I advocate from a systems point of view or clinical point of view or, all that is important anyway. Yeah.
There's not as many clinical leaders in management of hospitals now as there used to be. And
Yes.
there are a lot of doctors who are finding their voice around having
Yes.
clinicians at the table.
Yes.
I think it's a really important point that you're
Yeah.
making and set of actions that you've taken that you're saying, well,
Yeah.
if I do ever want to have a seat at the table, if I do
Yeah.
want to bring the clinician's voice, or if I do want to help the clinicians I work with understand the administrative position,
Yeah.
I,
Yeah.
I need some more knowledge. And it strikes me in the work that I do coaching doctors that very
Yeah.
often there's a lot of years and years of work going into
Yeah.
clinical technical expertise
Yeah.
and a sort of assumed idea
Yes.
that I'll be able to do
Yes.
the leadership stuff or
Yes.
people management
Yeah.
stuff or the money management stuff.
That's
And
right.
it doesn't really make any logical sense, does it?
Yeah, yep. You're absolutely right. There are multiple different skills that are involved. And I think the pendulum is swinging, isn't it? So a long, long time ago, hospitals were probably very simple institutions. Now we've piled on so many things onto this particular institution. And so the complexity of it means that the doctors probably shouldn't be running it or the nurses shouldn't be running it. And we give away the power to administrators. And then you realize that it's all then big swung to one direction. There was just a recent paper that suggested that even from a hospital business point of view, involving expensive consultancy or managerial things don't necessarily equate to better patient outcome or even profit making. So
Mm,
we still, I don't think, have found the gold or the key or the answer to this. But I think somewhere in between those two worlds, so the corporate world and the medical world, there has to be an answer to how we can make hospitals safe places
mm.
for, not just patients, but for the clinicians themselves. I mean, you're the one who has been on this field, right? You know that doctors, nurses, allied health, and clinicians in general are living in a space where there's so much demands placed upon them from the
Mm,
system on the outside and from them on the inside as well.
yeah, it's really the pressure's coming from all directions. I think that is something I didn't anticipate, but I didn't
Yeah.
think I would build a set of knowledge about people who work under pressure. But I
Yes.
definitely am
Yeah.
building that understanding of what it's
Yeah.
like to work under pressure.
Yeah.
And that's all kinds of clinicians, really at all stages of their
Yeah.
career.
Yeah.
It's sheer number of population and the sheer kind of pouring in of patients that's constant. You don't really have to
Yeah.
look for your customers, do you, most of the
Yes.
time?
Yes.
That
That's
by
right.
itself is a pressure.
Yeah.
So just to go back to when you first came to Melbourne, and then these,
Yeah.
these multiple stacked on recalibrations. You changed a course studies, or you developed beyond where you started.
Yeah.
You had family that were overseas, and now
Yes.
you were building your own family here in
Yes.
Australia.
Yes.
You were on rotation, like all junior doctors
Yeah.
are, exploring
Yeah.
and testing other things. What
Yeah.
what were you doing? How did you keep yourself recalibrated? What were you doing? What were the skills or the supports or the resources that you needed
Yeah.
so that you could kind of just keep going with the flow and managing the changes and the transitions?
Yeah. That's a challenging question to answer, isn't it, Sharee? Like, I don't know who I am 25 years ago and who I am right now. Would I have made decisions differently, knowing what I know now? What would I say to my 25-year-old self 25 plus years ago? Um, yeah, we all think, okay, I have to get through Bachelor of Science to get through medical school. I have to get through medical school so I can get internship. I've got to get through internship so I can get onto my surgical training program. Got to go through selection. Once you go through selection, you have to pass your exams. Then you have to get yourself a job or fellowships, and all of that. So at every single point, there's always, I guess, recalibration. You're always changing the direction, always changing plan. I'm particularly kind of aware that there's a lot of, kind of the challenges of a junior doctor and the challenges of the mid-career doctor, the challenges of the consultant can all be very different. I feel for a lot of my junior doctors who like they want to get onto ENT or plastics or neurosurgery or psychiatry or emergency and they have to keep changing plans because sometimes the jobs are locked up or there are no opportunities. It's a real challenge in that sense. And I actually had that kind of times as well when I was thinking, okay, if I don't get into surgery, what's my plan B? If I don't get into general surgery, what's my plan B? Or if I don't get into plastics, ENT, what's my plan B? Um, and you just kept working hard and trying and trying, trying. So I don't know that I have a very specific answer other than to say I just kept trying and I knew that if I work hard enough or tried hard enough or be as sincere as I can or do a good job as I can, um, the worst case scenario is I'll still be a doctor, maybe not in that one specialty that I want to do, but I'll still be a clinician somewhere, I've always felt that there was that safety net. Once you pass medical school, you do a good job and be a good clinician, there will be a job for you somewhere. But yeah, living in that space, living in that tension between wanting to be a particular specialty versus being ready to be open to do whatever I end up doing, Yeah.
My experience of you, Eric, is that you do have a general optimism. Your part of your personality is that you're optimistic or hopeful, or
Yeah.
that you have a positive approach to things.
Yeah.
What do you say to junior doctors who are struggling to maintain that, who are
Yeah.
feeling dejected or just in despair, or
Yeah.
there's a sort of a learned hopelessness sometimes
Yes.
for young
Yes.
doctors because
Yes.
they're so low in the hierarchy and they do
Yes.
feel like they don't
Yes.
have enough power to kind of
Yeah.
make things happen. And
Yeah.
it is competitive. There are
Yeah.
bottlenecks in training
Yeah.
programs and places like that. How do
Yeah.
you encourage them or help them to keep going? What's your wise words of advice?
Look, it is hard, and I just often want to sit in that rubble, to say, look, it is hard. And it's not because we make it hard. It's just a numbers game, unfortunately. There are only an X number of positions in training for this particular area in this particular city. And sometimes this particular specialty becomes more popular than others for whatever reason. There are all of those seasons, and sometimes I just have to say, look, you have gotten through medical school training and you're an intern or a first year, second year, third year resident. You're trying to be a good doctor and you're trying to look at the future as well. I sometimes just remind them again to pull back and just say, listen, you know, um, you go to work every single day, even if it is just, and I still remember this when I was in my second year as a resident. Even if all I did that day was do some paperwork, put in some IV lines, insert some indwelling catheters, and chart a few things, I'm still seeing patients and I'm still interacting with people who are there not for their own choice, but because they had to be there. In a sense, there is that kind of human side of us, right? I need to remind myself firstly that even the littlest thing I do for patient actually do matter for them. Even the IV line that I put in, the chart that I write up, or the medication that I write up still matters for them. So to me, I often start with that baseline. And then I'd say, look, at the end of the day, you have goals, you have wishes, you have hopes, and unfortunately, life sometimes throws different hard balls at you, and you keep trying, you keep trying, you keep trying, but you always have to have your plan B, your plan C as well. Kind of keeping your options open is another important thing as well. Yeah,
I'm not a drawer or a painter, but I wished I was because I have this vision of you sitting in the rubble with, you
yeah,
know, a much younger doctor, and what a
yeah,
powerful image that is to have a senior person who's willing to sit with you even for a few minutes and just lament the
yeah,
the
yeah,
struggle, because there is a struggle. And you're also reminding me of a young doctor I worked with very, very early in my coaching doctor's time. And she was, I can't remember if she's in her intern year or her second year, but she said, I feel like a glorified secretary. And I didn't know that I'd done all this
yeah,
hard study just to
yeah,
be a secretary.
yeah,
And I said to her, what are you doing? She described the charting and the things that you've just described and chasing results and so on. And then I said, so what would happen for that patient if you weren't doing
mm,
those things?
mm,
And it
mm.
was really a watershed moment, I think, for
Yes,
her and for me in
yes,
my learning about a junior doctor's life.
yes, yes,
And she told me later on that she was now able to go through her days and leave work feeling like she'd really contributed and she'd been really useful, where
yeah,
before that she was really very dejected and like,
yeah,
what's the
yeah,
point of all that hard work I did?
yes,
I
yes.
think you're recognizing that too. Do you think that when you got to be a consultant, maybe let's move forward a little bit, was it how you thought it was going to be? Like by then, had you been in medicine long enough to have a kind of realistic view of what it was really going to be like? Did you know you were going to work these really long days and that you were going to interact with so many people and fix and solve so many problems in a week, every week, you know?
Uh, I wish I could have said that, oh yeah, I knew this was what I was gonna walk into. So still not. Even till today, even till this weekend or last night, I still think, oh my goodness, what am I doing with my life? I just want to be home a lot more. Um, and I think that's the challenge, isn't it? So, um, I still remember very clearly writing a tweet when Twitter was famous back then. I wrote down a tweet. I'm finally a surgeon now. I have control over my life. Ha 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 ha. Just LOL, 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 LOL. And then people knew that because, people think that as a consultant now, I have control. Yes, there is a little bit more control. Yes, as compared to my days as a second year, third year, fourth year resident,
Mm,
where I was a slave to the pager,
mm.
now I can control things a bit, but it's not that different either. I thought I was going to have a lot more control, but as it turns out, not that really. I mean, it comes down to the fact that the moment you choose the path of being a clinician or a surgeon or a physician or critical care physician or a nurse or anything, it's a life of service, and whether you like it or not, it is a life of service. And so I still have to turn up, even those days when I'm not really feeling like it. I still have to turn up because I've got 5 patients booked for an operation this morning.
Yeah.
And so there is a certain sense of duty that continues to drive that daily activity. Um, yes, you do get a bit more control, but not as much as what everyone thinks there is. I think I remember reading, was it Barack Obama's memoir or somewhere? He said, you think that the life of a president of the USA, that you have all control. Not really. You go from meeting to meeting. You're taken from places to places. You have duties and commitments and responsibilities that you have to do, and that's just part of the job. And so that's to a certain degree, that's how I feel. Um, you know, Touching back again about just I feel like I'm a glorified chart person. At the same time, I saw there's also that particular phase in life where, yes, understanding the importance of giving orders, receiving orders, doing the right orders was important. All those things really were character building or skills building towards the long run. I still write medication, as a surgeon, as a consultant. I still have to check bloods and I still have to know all of that. But that has become a natural, easy thing to do. But because those skills were built over many, many years. I graduated in 2005. I've been a doctor now for, yeah, 21 years and 10 of it as a surgeon. I still have to read charts and write charts and all those things. So nothing is ever wasted.
Yeah, they're the foundation skills in many
Yeah.
ways, aren't they?
Yeah, that's
So,
right.
and we know that practice is what makes those skills.
Yes.
That's mastery.
Yes. Yes, that's right.
Yeah. So I wonder, on this journey from school and deciding to do psychology and then medicine and then all the consultants and the fellowships and now coming to this place where you have your own, you are choosing at some level the balance between how much public, private, and in your own clinic work
Yes.
you do. And yes, your values are very alive in terms of service. If
Yes.
you feel that level of service, that's values alignment, and so you
Yes.
want to keep showing up even on the days that you're tired.
Yeah.
Have there been any dilemmas or crossroads? I'm wondering, for instance, when you've got some kids,
Yes. Yes, that's
and
right. Yeah.
they were
Yeah.
small babies, and also I'm thinking about the two of you are both doctors with
Yes.
on-call
Yeah.
responsibilities and these obligations of service.
Hmm.
How do you manage all of that home life stuff?
Uh, Terribly. I don't think I'll be where I am if it wasn't because of all the sacrifices that my wife has made as well. So yeah, we got 3 kids now. One is in year 12, year 8, and grade 6.
Mhm.
My year 12 boy wants to do medicine as well, and I um regrets in life. So one of my biggest regrets. So like I started the journey towards surgery when he was born. So like I said, I've been a doctor for 21 years now. So I started my surgical training basically when he was born. And I always have at the back of my mind, I just need to get through surgical training so I can spend more time with him. And then I just need to get through the exam so I can have more time with him. So I need to get through my fellowship so I can have more time with him. I need to set up my private practice and get established in Melbourne so that my life is safe and secure so I can have more time with him. And the next thing you know, he's in year 12. And next year, he probably doesn't even want to be with me anymore. He's probably going to do medicine somewhere in another state. I don't know. But that was a real regret. I had breakfast with him just a few months ago, and I openly said, I am sorry. As a father, that's one of my biggest regrets is not having enough time to spend with you because I started surgical training when you were 0, when you were 1. Um, and that has been the kind of always at the back of my mind. Could I have done things differently? Could I have done things better? Have I spent too much time in surgery? Because there is a minimum duty requirement in it's I can't just operate on a patient and just say no, I'm not going to be on call for you. Yeah, so that's a real balance as well. And the other thing as well, unfortunately, I've chosen the life to do quite a lot of public work. Some of my colleagues probably spend 80% of that time maybe in the private, and only 20% in the public. I'm almost the reverse. I'm spending 75% of my time in the public with the commitments of being part of leadership, teaching, education, and all those things. These are the things that I do enjoy. And that's why I love the teaching, I love the operating, I love the engagement with trainees. But at the same time, it is costly from a time and emotional and cognitive point of view as well. So I don't know that I have the easy answer. Maybe I should be the example of what not to do, Sharee.
Well,
Um,
I'm not sure about that, Eric. What I'm really noticing is that the reality of this, that we're
yeah,
not trying to paint a here's the perfect picture or here's the
yeah,
recipe, because there isn't one.
yeah,
The benefits, we can make arguments for any of the sides we want, can't we?
yeah,
The benefit of you doing work that's fulfilling and
yeah,
challenging and that you enjoy
yeah,
means that you come home in a certain state
yeah,
to
yes,
if you were doing something you didn't like. What I do hope the listeners are listening to is that there is a choice in this and that we
yeah,
are responsible for our choices. Whether we regret them or not,
yeah,
there is an element of being responsible for our
mm,
choices. A lot of early consultants come to coaching saying, that they don't know what to do because they're not on the prescribed track anymore.
yes,
And
yes,
so I think
definitely.
this time of trying to work out, well, will we have children? Won't we
Yeah,
have children? Will we move interstate? Won't we move interstate? How much of a commute can I tolerate? Because that's
yeah,
more time away from my family. All of these
yeah,
things are real, day-to-day
yes,
dilemmas that people are grappling with. And
yes,
for any audience that's listening that's not a healthcare worker and particularly not a doctor, I think there's so much unseen work that doctors
yeah,
do that we don't appreciate. We just, as members of the community, think, oh, well,
yeah,
when the doctor's not with the patient, they must be at home with their family. And
yeah,
of course,
yeah,
that's not the reality.
that's true. Yeah,
The,
yeah,
the other thing that you're pointing to is the variety in your work, that
mm,
going to the
mm,
public, being part of the public institution
mm,
gives you more variety in terms of
yes.
leadership and teaching and so on. And I think that's something that is of value as well.
Yes, yes. I think you beautifully kind of summarized that. When I told my son, are you sure? Haven't you seen how mommy and daddy work? I do 60-hour weeks. My weekends, are, caught up operating once in every 3 weekends. We don't do too many weekend on evening things, and stuff like that because I've got meetings in, 2 out of 5 evenings on a weekday and all those things. And he just said, but you seem to love what you do and your job seems really, really interesting and exciting. And that was what drew him to medicine or surgery in particular. But you're right. I mean, the various different varieties, you've nicely put it all together by saying that these are the little passions that I like or that I enjoy that at least gives me a sense of purpose or give me a sense of pleasure. There's always that question about, joy in work, seeking the joy in work. I find that for me anyway, speaking personally, joy is the secondary side effects of purpose. What I mean by that is what I'm looking for is not, I don't necessarily come to work wanting to be happy. I want to be useful. And when I feel that I'm being useful, that's when I get the joy, as a secondary after effect of knowing that my work matters and that is purposeful and impactful, Yeah.
So beautiful, Eric. We wish that for everybody, right? That they
Yeah.
can have something purposeful to do in their day, and
Yes.
that out of that comes these other things like joy.
Yes.
Yeah.
Yes. That's
So
right.
you post on social media, and I want to talk to you about that in a little bit. But one of the things you sometimes post about is getting the coffee for the team.
Yeah.
And so I wonder if you just say a little bit about your ideas about leadership or about teamwork,
Yeah.
whatever angle you want to come in there. It
Yeah.
seems it is a part of this joy element, I think.
Yeah. Yeah. It's the love language, isn't it? Like I come to work, and it's very interesting because every single day I would be working in potentially different
Mm.
locations with different teams in the operating theater. And a lot of studies, you're a psychologist, so you know all these studies that the culture of the team matters, and to me, the simplest way that I can influence culture is just by being kind. And so that kindness in medicine and surgery is really coffee, chats, conversations. The intensity of the work that isn't reduced. We still look after really sick patients. But when you have built that little coffee conversations, kind of little jokes here and there, things that break the ice. Then during those times when high intensity work needs to happen rapidly, then you've already created culture that creates the foundational thing of the relationship. So to me that I don't know, that comes naturally to me because I always think about that maybe, but it seems to me that it doesn't always happen everywhere. I tell some of my students, you're always welcome in every operating theater, but before you go in, just peek into the room and just have a look at the expressions of the team members. If you see a lot of really stressed out nurses in the corner, that's probably not a good learning experience for you because that's a potentially an unsafe working environment in that there's a lot of tension, there's a lot of communication issues. Maybe if you want to step into an operating theater, see if you can find one where there's a little bit more relaxed body language, and that's probably where you probably learn the most. So I kind of give this little warning, but I'm sure if you're an observer for teams, that's something that you might see as well. Teams with very strong hierarchical structures might be more rigid and intense. Teams that are perhaps more psychologically safe probably have a lot more natural body language that are a bit more comfortable. Do you have anything to say about that yourself, Sharee?
Oh, yeah. I think you're pointing to a couple of really important things, Eric. One is that we know that we learn when we're relaxed, when
Yeah.
we're stressed out, we're worried about survival and staying safe. We can't actually take in and remember things very
Yes.
satisfactorily in that condition. So,
Yes.
absolutely, I support that. The other thing that you're pointing to, I think, is that the research around trust says
Yeah.
that it's really about competence first and relationship second. So,
Hmm.
when you meet somebody new, but
Hmm.
in the theatre, if you're working
Hmm.
with somebody you haven't worked with before, you
Hmm.
want to know something about their level of competence. You want to know how much support they need or how many instructions you need to give them. So once you have an assessment of their level of competence,
Yeah.
it really comes to relationship. And if you think
Yes.
of people you know well, who you've had long relationships with, you give them the benefit of the doubt. If something
Yeah.
goes wrong, you give them the benefit of the doubt
Yeah.
because you've got established trust through
Yeah.
relationship. But at the
Yes.
beginning of a interaction where you don't know the person, it's more about competence because
Yes.
you know
True.
you. And so what you're describing is these building of relationships that
Mm.
allows trust to build.
Hmm.
And
Hmm.
so you still need competence,
Yeah.
but because you've known their name or
Yeah.
because people feel
Yeah.
because people feel
Yeah. That's right.
seen and heard.
Yes. Yeah.
This act of saying, what kind of coffee do you want? Or I brought you a
Yeah.
coffee, or does
Yeah.
anybody else want a coffee?
Yeah.
That's an act of I see you.
Yeah.
I want to know about you, or I want to do something to
Yeah.
connect with you.
Yeah.
The Gottmans would say that's an act of looking for connection.
Yes.
These
Yes.
are really important things in trust, and the
Yes.
other thing you're pointing to is that it's momentary. It
Yes.
can sometimes take just a few seconds,
Yes.
but the value of the person feeling seen and heard means that now they trust you. They think, oh, he
Yeah.
saw me. They
Yeah.
want to trust you. And they
Yeah.
still need to know you're competent, but they're already ready to give you the
Yes.
benefit of the doubt because
Yeah.
they've connected and built some sort of
Yeah.
fledgling
Yeah.
relationship with you.
Yeah. 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 Yeah.
It's powerful stuff. I have a favorite thing of saying that the art of medicine enables the science, and I think that's the
True.
territory that we're in, that
That's
we can have
true.
all the magic of modern medicine,
Yeah.
but if we can't get the other person, our team members' attention, or if they won't speak to
True.
us, or,
Yeah.
then we
Yeah.
may not be able to deliver the magic that the technology allows.
Yep, yep. No, that's very true indeed. I mean, I've seen that again and again in teams. And maybe this is just because all through my training as well, I've chosen role models that actually embodies that as well. I've seen enough, I know enough people with long titles over their names
Mm,
that probably a very different person in clinic or in the operating theater. And
mm,
I've seen others who are effective leaders with no fancy titles, but really is a master at getting the team together and getting good results for their patients. So, the academic titles versus the day-to-day practice, they're two very different things sometimes. And I guess I've always wanted to model myself following the model of those people who really empower their team and just nice to
yeah,
work with, nice to work with.
yeah,
Brings a lot of comfort to me even as a junior in their team.
yeah. You used the word power earlier, and now you're talking about empowerment. I mean, even just to notice these things and name them has an impact. If people have an idea that their colleague is interested in empowering other
Yeah.
people, then
Yeah.
they respond differently and we lose our voice. We had Victoria Lister on the podcast a few sessions
Hmm.
ago. She studies how people have their voice or become
Hmm.
silent at
Hmm.
work.
Hmm.
And, the numbers are pretty frightening. It doesn't take
Yeah.
very many times for people to stop saying something about patient
Hmm.
safety
Hmm.
or about um, the bullying that's happening or the other
Yeah.
things that might be happening between colleagues. So having people around who will name things like, um, I want you to feel empowered enough to speak up
Yeah.
if you
Yeah.
see something.
Yeah.
That has a big impact. Yeah.
Yes. Yes.
We've talked a lot about your identity. We've talked a little bit about your identity as a dad. We've talked about
Yeah.
you as a surgeon and as a student and so on. You have this social media profile that sometimes you're quite active on and sometimes you go quiet for a while. I
Yes.
think I've learned things like you used to have a rabbit at home and we have a rabbit here, so
Right.
I've noticed that and the
Yeah.
coffee. And you
Yeah.
posted a couple of things recently. You've posted about the hours and the years of study
Yeah.
that you've done. But you posted a very graphic image recently, a couple of things, one with blood all over your face. I think that was at Christmas last time when you
Hmm.
had been
Hmm.
in the surgery. And another one where there was some reconstructive surgery. I can't remember what the
Hmm.
case was. You
Hmm.
showed the number of people in the room,
Hmm.
the pre-team and the post-team, if you like.
Yeah.
Um, what's your hope or intention when you're showing those real life images of
Mm,
your work?
mm,
What do you
mm.
hope people
Yeah.
learn when they see those?
I guess the humanity of it all. What I mean by that is, people might think that the surgeon always leave unscathed. We actually carry our battle scars. What a lot of people don't realize is people say, oh, that doctors change lives and things like that. Well, the reverse also happens. Patients actually change lives. Patients change our lives, or patients affect us, or we carry a lot of our patients, and both the good and the not so good. What I mean by that is, when you see one of my youngest patients who had cancer is a 5 kilogram 3 month old. And that patient will stay with me for a very long time. He's alive, he's well. This was about 7 years ago. But to walk with a new parent talking about their child having cancer and being treated for that, it's a massive thing. That's on one hand. On the other hand, when I've got the 18, 90-year-olds with malignancies of the tongue or the face, that's another different discussion as well in their different contexts. But what I really wanted to show was just the humanity of it all, that we do carry our patients home. We do feel for our patients. They are more than just cases or tasks or jobs to be done. And it does affect us as well. And I think maybe a lot of people don't realize how much a lot of surgeons actually do think about their patients and carry them home. And maybe that's all. Maybe this is also an expression because um, I happen to be on social media and I happen to be quite honest with my sharing of the busy life, the sacrifices. And that's not to get a pity from people, but that's actually just to show the reality of it all, that the work, takes a lot from
Mm,
us.
mm. Yes, it does. I want to come back there again too, but before we do that, there's a bit of a push right now for more doctors to be on social media to
Mhm.
counter these non-doctors, non-clinicians who,
Mhm.
let's say, propagate a lot of misinformation. Let's say it
Mhm.
like
Mhm.
that.
Mhm. Yeah, yeah,
What's your advice to other doctors who might be
yeah,
contemplating, maybe I could be on social media,
yes,
but who feel very wary about the regulation, the
yeah,
regulatory rules
yeah,
around those kinds of
yeah,
things?
yeah,
What
yeah,
have you
yeah.
learned? What advice might you offer in that
Yeah,
sense?
interesting. I've been on social media since I started my surgical training. I was under anonymous because I wanted to try and explore different things, first of all. I think social media is a medium. It really is just a medium. You can use it for good, you can use it for bad.
Mm.
I think there was a recent quote that says, "Why are doctors now becoming influencers?" Well,
Yes, I saw that.
because influencers are becoming doctors now. So in a sense, all that we're doing is putting on social media what we repeatedly do on a day-to-day basis. And for me, that's just education.
Mm.
I don't put stuff on social media so that people can see me in my private clinic. In fact, most of my followers and other things are probably not even in Australia. I put social media really as an educational platform to share, basic, simple ENT, ear, nose, and throat related stuff, life of a surgeon, and also just being a human being, being a dad with a life outside of the operating theater. And my encouragement for anyone, any clinicians, doctors, nurses, allied health, is to say, well, you're a professional at work. You can be the same professional on social media. You can tweet about or share about what you do. Now, you don't talk about patients, but you can talk about conditions. So that's kind of my simple line. Don't talk about patients, talk about conditions. You can talk about what you do. You don't have to say that you're the best at doing this. You just share what you do. And that's not to draw attention to you, but that's again to really just put some neutral information that is helpful for the public to engage with. There are some clear guidelines in Australia, but basically you can say what you do. You just cannot say that you're the best at doing it. You cannot promote unnecessary services, meaning you can't say, if I take your right tonsil, I'll do your left tonsil for free. You can't do any of that. You can't put any patient testimonials. Those are some general rules. So my guideline is basically simple. Talk about conditions, talk about what you do, educate, 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 and stay professional. Being a professional at work, being a professional on social media will be helpful for a lot of people, I think.
I really appreciate seeing you there. I think you obviously have been doing it for a long time. I think there's
Yeah.
a handful of doctors in Australia really showing us very beautifully how you can educate
Yeah.
in the way you've
Yeah.
just described. But before we went there, you were also talking about the impact of being a surgeon, how that affects you, and you've done some talking in the world about the well-being of surgeons.
Yeah.
Can you share with us some of the key messages are what you think other surgeons in particular, might
Yeah.
want to
Yeah.
think about?
You mentioned very briefly in the past during recalibration. So I had my burnout period, a really, really burnt out, actually not through training,
Mm,
but after training. So after I finished my fellowship, I got really burnt out. And that I think is partly because during training, I always had something to look forward to. I had to finish my exams, to finish my fellowship, finish this, and that. And then after you finished everything, you're kind of like, okay, so what's next? And I think that point of recalibration also was a point of, okay, I was really, really burnt out at that time. And I still remember very vividly one news where, I'm sorry about this is trigger warning, but there was a gastroenterologist in Brisbane who completed suicide, and his wife actually wrote a very powerful, moving letter about how work really affected him. Some patient complications and other things really, really affected him. And I know a couple of other clinicians who have passed away as well in the context of work-related kind of stresses. So I came to that season of life realizing that I could be the best trained surgeon in the world, but if I don't kind of look after my own soul and heart and humanity, I may not be alive in a few years. So I had to face my own mortality, I guess. And I think that's when I started talking about what are the things that we have lost as a surgeon. We've lost our sense of autonomy sometimes. Our work-life balance is taken away from us because we are a slave to our pager sometimes. We've lost a sense of community. The life of a clinician. Again, I can only speak for myself. The life of a surgeon can get pretty lonely because even though I'm surrounded by registrars, trainees, and other things, at the end of the day, the patient is still mine, and every complication that happens or every poor outcome that happens, I do take it on to a certain degree personally. So those were some of the dark moments: the autonomy, the lack of community as well, and the repetition of routine that gets taken away from us. And so some of the things that I encourage my colleagues to do is to return to some of that. Get some autonomy over your life or your career. If there are sections of your work where you find the least where you're least autonomous or you're unable to make decisions, maybe those are the things that are eating away at your soul. Are you able to find other parts of your career or your life where you can feel more autonomous, have a bit more autonomy? The other thing is forming communities, have a group of colleagues, and they don't have to be medical colleagues. They don't have to be another surgeon or another clinician. They can be people from your faith communities, from your your sport communities, and all of those things. Just building around that. Those are probably some of the simple things, and it probably is so common sense to you and to many people, but I guess it's just something that just needs to be mentioned again and again. That the pressure of clinical work, the pressure of patient expectation weighs heavy on us. And so we need to find a way to resolve that balance with autonomy, joy, meaning, purpose, community.
Yeah, beautiful. I'm noticing that you're using the word soul, which we had a psychiatrist, Ashok Bhattacharya from Canada on about a month or two ago, and he was talking about soul and spirit as well. And I
Yeah.
think, these are very non-medical words, Eric. um, I love that we might be entering this space
Yeah.
where people can use this language
Yes.
beside the medical language. It's not either or. It's that, these are ways that humans for millennia have
Yes.
described something
Yeah.
about their experience of being human.
Yes.
And
Yes.
surgeons are first and foremost humans before they're anything else.
Yes.
So
Yes.
I
Yeah.
really welcome that um, apparent progression that we're
Yeah. Yes.
we're
Yes.
or you talked about pendulums before, perhaps the
Yes.
pendulum coming
Yes.
back a bit.
Yeah.
What's important to you about having these conversations? You've done some writing over the years as well on social
Mm.
media, and you're talking at the conferences. What's important about talking about these issues, not just talking about your ENT specialty and your administration skills and so
Mm.
on, but this human stuff? Why is it
Yeah.
important for you personally to keep talking about that in a public way?
Mm. I think for me, it's that a collision between your work and who you are. It's very hard. People talk about how we are human beings, not human doings, but at the same time, what you do really does matter. And I think, as you've said, you just can't split them. One impacts the other. You need your human doing and to support your human being, and you need who you are as a human being to support what you do. The quest, I think, particularly for clinicians, is we derive joy from, I guess, the deepest joy that I have in work is seeing my patients get discharged well. When they can return to their daily activities being better, sleeping better, breathing better, hearing better, eating better. ENT is about,
Yes.
senses, right? So if they hear better, see better, sleep better, breathe better, and they are better, that's kind of the deepest joy. It's not, the status or the financial, kind of all of that remuneration and all of that. It's always that kind of human meaning. And that's the thing that is long lasting in my mind. And I think this is also the antidote to, I still don't know how, maybe you can give me the answer. Maybe you have the equation, but the equation in my mind is a lot of clinicians are burnt out. And we're trying to find individual solutions like, mindfulness, yoga, all of that stuff. The system is not causing, but have some association with that. But at the same time, the antidote is actually altruism. Seeing a patient get better is one of the biggest kicks that we get. So in that triad, the system, the clinician, and the patient outcome, I wonder whether, the patient outcome is the antidote to the burnout. Changing the system is the antidote. So I don't know. I don't have an answer to that, Sharee. Maybe you have. But
But
for me, I think the reason why I still love talking about the human side of surgery is because that's the thing that will get us going in the long run. Surgical skill, surgical knowledge will keep changing, but it's the human behind the knife that I really care about as well. In my colleagues, in my registrars, in my trainees, I still want to be a voice in that space because that's probably the long-term antidote to the burnout and the mental health effects or negative mental health effects on our work on us.
mm,
I don't know. Maybe can you piece it all together? What's confused in my mind, Sherry?
we could do this we could be here for hours, Eric. The system, clinicians in systems, whether they're in any country in the world, I've got a lot to learn about China and some of those countries I have less contact with. But certainly in the UK, in Europe, in America, in Australia, New Zealand, South Africa, a lot of these countries, Singapore,
Yeah.
the systems are different in a lot of
Yeah.
ways, and the problems are still the same
Yes.
for clinicians. So
Yeah.
it's way too simple to say it's the system's fault because
Yeah.
even with the variations in the system, we still end up with some of the same problems.
Agreed. Yeah.
And we know that not everybody burns out. So it's
Yes.
not, even though the numbers are very high, way higher than we want them to be, it's like saying it's not like every child of a person who abuses alcohol also becomes a person who
Yes.
abuses
That's
alcohol,
true.
right? So
Yeah.
we can't just say it's the system that's causing burnout, and you checked yourself about that association.
Mm, mm,
And we know that practices like mindfulness and staying present and
mm,
doing work in the team where we're
mm,
feeling seen and heard,
mm.
feeling psychologically safe, we know that those things are helpful for individuals, but they're not enough either by themselves.
Yeah.
So, it's a combination, as you're
Yeah.
rightly pointing to, of all of these things. The research from Mayo Clinic and places like that certainly says that it's unit specific, that we
Hmm.
can't apply a recipe from one unit to the other and
Yeah.
assume it will work. It needs to be localized.
Yes.
And we know, I'm sure you're aware of the leadership research, your one-up boss is
The
70%
biggest. Yeah.
responsible
Yes.
for your
That's right.
level of happiness at work. But I
Yes.
think you pointed to something much earlier that was very important, which is this sense of purpose,
Mm,
the story that we're telling ourselves, the
mm.
meaning making
Yeah.
that we're doing of our work
Yeah.
is critical in our sense of well-being.
Yes.
And the other thing I'd point to is that outcome focus is incredible. Like seeing your
Yes.
patient work or walk
Yes.
away more well than they were, have
Yes.
some of their issues resolved
Yes.
or their life extended, or that's a
Yeah.
very powerful motivator, but
Yeah.
it's still extrinsic to
Yeah.
us.
Yeah.
So that outcome base isn't enough. It
Yes.
has to be some intrinsic
Yeah.
motivation, something,
Yeah.
your sense of, you said before, I want to be useful. So
Yeah.
this sense of feeling useful in the process, even if the outcome is not the desired outcome,
Mm, mm.
is
Yeah.
also important in our
Yeah.
well-being. This
Yeah.
sense of I've done everything that I could do, that I
Yeah.
had the capacity to do, that the resources allowed us to do.
Yes.
I met the actual person, I was present to them, as
Yeah.
opposed to being a robot.
Yeah.
Um, I was compassionate to that
Yeah.
extent. Those things all help us be well. So,
Yeah.
I think you're definitely onto something with
Yeah.
all the moving parts.
Yeah.
I
Yeah.
don't think either of us can claim to resolve all
Yeah.
of that right now. But
Yeah.
this conversation, it's a very important conversation that people are having now on a day to
Mm,
day, and I think
mm,
that's going to serve us well.
That is true. That is true. Yeah.
Let's kind of bring our conversation to a close, Eric. I
Mm,
feel like
mm.
I really took over then for a minute.
It's lovely. It's lovely to hear because these things do matter, and I think people forget that because do see that the solutions don't often answer the underlying issues, and understanding there's various parts there is quite important, you know.
We haven't talked a lot about teams, but I wonder if I can just ask you about that. There is a hierarchy that operates in
Mm,
hospitals,
mm.
particularly,
Yep.
and consultants are further up the hierarchy than lots
Yep.
of the other people, the techs in the theatre space, the
Yes.
nurses.
Yes.
What's your reflection on how people can do well in a
Mm,
hierarchy? I can't imagine that in
mm,
the short or medium term, the hierarchy is dramatically going to
mm,
change.
mm.
So, what are the things that can help people from any of the different
Yeah.
positions to
Yeah.
work really well in a team from your
Yeah.
point of view?
Yeah. Yeah. I mean, from what I've learned is, hierarchy in itself is not evil. It just provides structure to a team. It's the abuse or the misuse of that hierarchy where the negative effects on a person is. And when you are in a trauma resuscitation, there's clear hierarchy because we do need clear communication guidelines in such critical times like that. But I think where people mistake it is thinking that this is a hierarchy of value, like that the theater tech is less valuable than the surgeon, or that the registrar is less valuable than the anesthetist, or I don't know. Interestingly, in Australia, if there is no theater tech, the whole thing gets canceled sometimes. So it's not a hierarchy of value, it's a role definition, in terms of that. So I know too that if we were having this conversation in, like you mentioned, countries like in Singapore or in China or in other places, those hierarchical structures are probably going to be even more strong and based perhaps either on age or gender or other things like that, where the cultural context really influence the hierarchy in the hospital. Now, all I can say is here, at least in our conversation here in Australia in 2026, there's a better understanding that the structure of the team or the roles of the teams are important, and clear communication is important. And of course, there's a lot of research on that. And I think we started earlier on by talking about coffee and how that matters, like forming or creating that trusted working relationship for the sake of the patient is quite important. For me, at least as a surgeon, I often it's interesting as well. When good things happen, everyone's the boss. When bad things happen, suddenly I'm the boss. You are in charge of everything. There's an interesting kind of play there as well. I mean, all I can say is that when I walk into the clinic or the operating theater and I work with different people, um, understanding that I'm just here to provide support, counsel, general guidance, is where I feel my role is, and that each person, obviously in the team, has got a very specific role to play. That is important as well.
I love that distinguishing that you're talking about. It's not a hierarchy of value. That's a
Yeah.
very beautifully expressed. Thank you. Anything that you've noticed in our conversation today while we've been talking, anything that's come up for you that you feel like you'd like to put a pin in or point back to in terms of reflection?
You mentioned stories and meaning. I think that's something that I would love for all of us as just human beings to tap into it a little bit more, It's just an understanding of the bigger narrative or the bigger story of our lives. And sure, we have to respect the fact that there will be people, clinicians, who are driven purely by status, titles, financial benefits, remuneration, all of those things. And yeah, I know some of them, I work with some of them, and particularly, unfortunately, in the surgical world, there is a lot of clinicians that are probably driven in that. Now, I have to respect that. That's their primary drive. But for the rest of us, for most of us, I think understanding the bigger stories of, the purpose of what we do actually really matters. And I keep falling back to that as one of the reasons why I feel, okay, when I'm really busy and I'm waking up at 4 in the morning, being called back into the hospital for the 10th time in the same week, I gotta say, all right, this is hopefully a phase of this life. It's just this season. But I've got a bigger thing to live for. I've got a bigger purpose. I've got a bigger story. And for the resident who've just finished the night shift and trying to get onto a, anesthetic training program, or, for the consultant whose, books are empty and it just started practice, understanding that context of story, I think is important in placing that as well. And I think the cold, sterile world of medicine and surgery don't often allow room for that to happen. There's a lot more understanding now, and people like you are pushing that understanding, which is really, really good for us. But yeah, I hope that we get a bit more megaphone towards that space of the humanity in surgery, humanity in medicine in particular.
I didn't think of it before, but I'm just remembering about the respect program that the RACS, the Royal Australian College of Surgery, have mandated for all surgeons. I
Yes.
think maybe it's been going for about 10 years now, which
Yes.
seems ridiculous that it's gone so
Yes.
fast.
Yes. Yes.
Do you think that that's made a difference? Has that helped these conversations now that there's this mandatory requirement?
It definitely has moved the needle. What I mean by that is that it was interesting that it started with a problem. There was bullying, harassment, and particularly sexual harassment around that time. I still remember this quite clearly. And out of that problem came a big cultural shakeup. And the leadership really just took ownership of it and then ran all this program operating with respect, putting language, putting concepts, putting language into a problem, into a communication challenge, into even more basic, into a human relationship thing, that respecting the people that you work with
Mm.
is how we as surgeons operate. And that's mandated across all. So that's definitely moved the needle. Of course, is it 100% perfect? Of course not. But it gives language, it gives thought, it gives time to think about those things. And I think it does matter now. Among all of my, a lot of my trainees and a lot of statistics that I work with often does say that yeah, things are changing now. Seeing the difficult to work with surgeon is becoming an exception now, not the rule. In the past, there's a lot of more challenging personalities. Now, I think we're a bit more aware that having
Mm.
those personalities don't necessarily mean a good outcome for the patient or the team. So I think that's it's important. So there's value that in understanding a problem, creating a solution, mandating that solution through a leadership and systemic change,
Mm.
which moves the needle. Yeah.
How encouraging. Great.
Yeah.
Any last words you want to offer? Any mantra that you use on a regular basis to keep yourself going when you need it? When you feel a recalibration required, something's happening that you think, oh, I really need
Uh,
to get recalibrated here.
we as clinicians, it's almost like we fall into this space between our patients expect us to have, work is everything. Because after all, if you're going to be operating on my child,
Mm.
you need to have, like work is everything that you think about. You do your best.
Yeah.
And on the other side is that spectrum of work is work. At 5 p.m., I sign out and I don't think about patients anymore. Um, on one hand, being completely fully devoted to work will burn you out much faster. On the other hand, just thinking of patients just as a job, it just takes away the humanity and the no, I don't know whether nobility is the word for it, but the noble calling of being a doctor or being a clinician. Somehow the answer is in between those things, isn't it? Like work is not everything, but patient is also not nothing. And so finding that space in the middle is important. When I meet with a struggling kind of resident doctor or junior doctor or maybe even colleague who are consultants as well, sometimes the thing that we go back to is at the end of the day, we're human beings. We have our limitations. We got to be aware and be insightful of those limitations. We will have some good days. We will have some bad days. And knowing that flow of the valleys and the mountain highs and the mountaintop and the valleys is just part of being human, isn't it? A few other things that I say to some of my colleagues is, sometimes the detours in life is exactly where you need to be, and I need to say that to myself as well, because there are times when I feel, why am I here? Why, I wish I can spend more time with my family. I have all so many regrets, but at the same time as well, looking back, I think at every season in life, you've just tried to give, your best to your patients, your family. And the other thing is as well, always thinking about, the bigger picture. We mentioned it, we touched on it, on that soul, that spirit, that story making. I mean, there's the faith part of me that kind of perhaps sometimes not overrule, but has a huge part of what I take meaning with, what provides me my work meaning. And that's something that I think, for people, whether it's art, music, faith communities, your cultural group, your family groups, I think meaning doesn't only come from the work in front of us, but from something around us or beyond us. I think that's one big thing. I would be dishonest if I didn't share that, faith is a big part that informs what I do. But at the same time as well, I think for a lot of people, even art, humanities, meaning from social cultural groups and families is the big part that informs what they do.
Let's bring our conversation to a close. That's a lovely place to finish. Thank you for your generosity and your optimism and all the things that you've shared today, Eric. I've really enjoyed talking with you.
Thank you so much, Sharee, and thank you for all the wonderful work that you do in this space. You're making a huge difference. Thank you.
Well, thank you. I hope you enjoyed that conversation with Dr. Eric Levi. He is a joy in his optimism and his enthusiasm for what he does. I think he gives us a really beautiful example of when we know what our purpose is, when we have a connection, an intrinsic connection to the work that we do, then even when it's difficult and it's challenging, there's a reason to keep showing up and there's a way to hold our balance, if you like. Not that Eric used that word in particular. He said some very interesting comments towards the end of our conversation about soul and connection to something bigger. And I want to really point to that to help us remember that as clinicians, yes, we have a very useful, purposeful job to do as doctors, nurses, allied health. There's a clear role for us. There's something that we're offering the community in our work. And we can't do that at the loss of ourself. We need to have a sense of who our self is while we're in those roles, because we're stepping in and out of the role. We belong to a bigger story than just our clinical role. And I think it was really beautiful to hear from a surgeon talking about the realities of his work. Eric has a lot of parts of his work. He's teaching, he's clinically very engaged, doing a lot of hours clinically every week. He is a beautiful writer, although we didn't talk about that today. He's been active on social media for a number of years, and I think he was very generous in sharing with us the ways that he thinks about that without being too kind of philosophical or theoretical. It's just he has a clear sense of why he's on social media, for instance. It's to educate, educate, educate. And so I know that the people I work with who have a clear sense of their why, what it is that they're trying to achieve, what their purpose is, the reason that they're involved in something, then it's much easier. There's an anchor when things become difficult or tricky, or even just when they're tired. So I hope you've enjoyed the conversation with Eric. If you have enjoyed and are enjoying the podcast, please share it with the other people that you know. And it really would help if we had some reviews on our show. So if you are listening and going along with us on Recalibrating with Sharee Johnson, please tap the review button and help other people who are working in healthcare find out about the storytelling that's going on here on this podcast. Until next time, may you be well.